The Arabic was good. Okay, thank you very much. So at least I got something to take home with me. That, okay, I don't think it's working. Well, I have a lot of microphones here. I feel like in a press conference now. When you think about suicide assessment, especially if you're starting off and maybe doing it for the first couple of times, I think it's always good to have some sort of a plan. And one of the things that you can get a plan is the safety. I mean, there are some steps that you could take, and the first would be to identify risk factors. The second would be to identify protective factors, to conduct a suicide inquiry, so directly asking about suicide would be the third step. And then you have to determine a risk level and sort of come up with an intervention. So what are you going to do now? And then never forget, document what you did. And we've talked about the CSSRS, and there's also, because this is by the US Department of Health and Human Services, Kelly Posner came also up with CSSRS that is particularly tailored to the safety model and comes up with some sort of a risk score, although there's not a real evidence for that, but it tries to sum up that in some sort of a sorted manner. You could find all these, put it down there on the CSSRS homepage, so they're all freely available. One other thing that you could keep in mind is the acronym is PATH-WARM by the American Association of Suicidology. So the I stands for ideation, the S stands for substance abuse, the P for purposelessness, the A for anxiety, T for trapped, H for hopelessness, W for withdrawal, A for anger, R for recklessness, M for mood changes, and the question mark stands for you have to ask, all of these things. This is just a sort of a reminder of the things that you need to look into suicide risk assessment. Then there are some personal risk factors, so I'm going around the risk factor literature now. Of course, there's age. We know that suicide is very rarely found below the age of 15. Then there's gender. We know that suicide is much higher in a male, and this is also true for young adults and adolescents. If they're single, yeah?
The risk factor is higher in males?
Yeah, more males commit suicide. Well, there are more females committing suicide, attempting suicide, but more males committing suicide. Although, as I showed you before, the Nagavi global burden of disease showed that on a global scale, they did not find this gender difference in suicide in the age group 15 to 19. But just talking from a European perspective, this is true also. We have a 4-to-1 ratio of adolescent suicide, male to female. Partnership, single, not having a partner, having a non-heterosexual sexual orientations like LGBT, these have a very high rate of suicide, having low social support, and for psychological risk factors, it's about rigid thinking and hopelessness, and low stress tolerance, and low emotional regulation skills, and having low coping skills when it comes to social skills, and deficient problem-solving skills. By the way, this here, Shield and Kutcher is a very good book on suicide risk assessment. It's a small, comprehensive guide, and there's a lot of really comprehensive knowledge in here. Then the family history of suicide. One of you said that before. I have to know if there are suicides in the family. Ask for suicide in close relatives. Is there a family history of any mental health disorder in close relatives? And what about the family situation? Is there a loss of parents, severe family conflicts? Is there inadequate parental support? Or are they frequently moving or changing home? This is a huge risk factor for adolescents. It may mean nothing to an adult changing where they're living every couple of years and moving, but for children and adolescents, it's a traumatic experience in some way, or it can be because they're losing their social circle and have to adapt to new circumstances. Then there are mental health risk factors. Of course, there are disorders you would like to look into. As I said before, it's severe depression and bipolar disorder, acute psychotic state, substance misuse, borderline personality disorder, and schizophrenia. And of course, this hopelessness, low self-esteem, deficient reality control, commanding voices, low mood, severe anxiety, intensive feelings of loneliness among the affective symptoms. They go for severe and repetitive non-suicidal self-injury as a risk factor. The higher the frequency, the more severe it is, the higher the likelihood of a suicide attempt. Could look for agitation and restlessness, for impulsivity, for aggression, and alcohol and drug misuse. And some other stressors, financial problems, legal problems, look into loss of schooling or work. Grief, meaning romantic grief, so they lost their boyfriend, lost their girlfriend, bullying or social rejection. And we have to be very well aware that these risk factors, they weigh much more in adolescents than they do in adults. So we must never never forget that those are people with shorter lifespan, so there are not a lot of experiences. So from your perspective, you might have the chance to see that a romantic relationships ends, and there's grief and a lot of tears, and you feel depressed. But after a couple of weeks, you will go back to normal, and you may find a new partner. But this is some experience that the normal adolescent, if they are 13, if they are 14, this might be their first romantic relationship, and it feels as if the world would end. And so there's much more weight on that loss of a romantic relationship than it is in adults. Of course, it's not fun losing a relationship, especially if you're the one that you're being left behind. But then it's much more severe as a risk factor in adolescence. Also, schooling. From an adult perspective, you often think that, okay, you have to do one more year of school because you failed your stats and you didn't achieve the class results, so you have to stay there one more year. From an adult perspective, if you lived like maybe 40, 50 years, you say, well, it's not fun, but hey, it's a year. But this can feel like the end of the world to an adolescent, because they will lose their class, they will lose all the social relationships, they will have to adapt to new things. And they have to stay in a system that they don't like maybe for one additional year. They can't get out of it. So for medical history, sleeping disorder once more, chronic pain, physical cognitive impairments, loss of sight or hearing, mutilations, feeling of being a burden to others. So you have the perceived burdensomeness in there once more. And of course, every history of child abuse and neglect increases the risk. And if you have a accumulation of different forms of neglect or abuse, the risk increases. So it's a simple cumulative experience when it comes to risk factors. The next thing you should always assess is media use. You probably all have 13 reasons why here as well. Okay, I see some nods here. If there's one person in this room who is treating adolescents and who has not seen 30 Reasons Why, go back, get somebody with a Netflix account and watch it, because it's the literature of the user you need to understand their codes. It's a lot of teenage drama in there, although it's a bit of thrilling. The book it's out for years now. I've read the book some years ago, and the book doesn't have that much of a problem, because okay, here's the spoiler now. Hannah Baker is committing suicide. And the way it is portrayed in the Netflix series, Certain Reasons Why, is extremely problematic from a suicide prevention standpoint. And what we have seen in research, because we're all waiting for effects to happen, and it did happen, because everything you could do wrong in depicting suicide was done wrong by 13 Reasons Why on Netflix. And there was an increase in the pediatric emergency rooms very, very shortly after it went on air, having more admissions for suicidality in comparison to the year before it was broadcasted. And in 40% of these emergency rooms, they found a copy suicide attempts 30 days after the series started or was broadcasted. We have a significant increase in suicidality in the US in this age group, which is kind of peculiar. As I told you before, the suicide rates are going down worldwide, but it increased since 2017 in this age group. And there are two different working groups. There was Ida Kottenthaler, who was a colleague of me at the Medical University of Vienna, and working group by Bridge, showing that the April 2007 in the United States, this was the time that the series was first broadcasted in the US, were the month with the highest suicide rate in 5 years in the United States, and they had an increase in suicide cases into what they would have expected from calculating it for 20 years before. 195 cases that are probably due, suicides that are probably due to 13 reasons why. So this is a huge problem, and me personally, I know some girls who refer to Hannah Baker in their suicide attempts, and this is also something, that's why I say you need to see it, because they're referring to her and they're saying, you know what, I'm feeling exactly like Hannah Baker. And if you're the person sitting across the desk and don't know who Hannah Baker is or what she's thinking, of course there's a good way to, okay, can you, I'm an old person, please explain it to me. I'm done, can you tell me what you mean by that? But you're still more in the game if you know what she's talking about or he's talking about. There is actually an increase in male suicide as well. And if you look into the series, and I'm hoping not spoiling as well, there's a suicide attempt by a male person as well. Yeah, you're right, you saw it. So you did your homework for child adolescent psychiatry, very good. So you need to then look into current and past suicidality. This is talking particularly about suicidality that has happened in the past and what is going on now. So looking into suicidal ideation, is it persistent over a long time? Is it intensive? Is it very recent? Is it uncontrollable? So do the people have the feelings that they can't handle the situation anymore, the thoughts are stronger than themselves? Is there a strong wish to die, a strong will to take action, and are they actually expecting death? Suicide plans, is it well planned? Is it a method with high potential lethality? I was talking about the train. You know what the method of suicide, the most used method worldwide of suicide adolescence is?
Cutting?
No.
Rodenticide?
No. Hanging. Yeah. So it's a very lethal method with a lot of access to. So we always talk about restriction to means in suicide prevention. You can't restrict the mean because all you need is a rope or anything. So hanging is the most, because it's a lethal method, so it's on top of it, and then it's jumping in front of a train, a car, whatsoever, and falling or jumping from heights. So we have very lethal methods on top, and intoxication is extremely common, but not as a method of suicide, because a lot of people survive after intoxication. Yeah. So they don't find it in the list of the top 3, although it's a very common behavior, because it's not ending in death. And then you have to look for past suicidal behavior, like suicide attempts in recent past, multiple suicide attempts in history, the low risk of detection when they did a suicide attempt. So that's a difference between those who are taking an overdose and know that the parents are coming home in 30 minutes, or those who are taking an overdose and doing this while they're in the forest, wide away from the next street or house or whatsoever. And I've encountered both of this. So was this a suicide attempt in the past with a low risk of detection? Was it well organized? Was it a method with high lethality? And did they have regrets having survived? Do you know how many people with a suicide attempt regret that they have survived? Just after they're in the emergency room and then recognized that they have survived the suicide attempts, how many people would say, I regret I survived at that point?
A lot. 50%?
Regret? No. It's only 10 to 20% regretters. Most people say, I'm glad I'm alive. Yeah? So most people, 80 to 90%, after attempting suicide, they are glad they survived, which feeds into the theory that this is a cumulative thing. And if you survive it, it can drop very fast. So this is the ideal moment when you need to enter and do something good for them and get into treatment, because you have an open room here. There are people who just attempted suicide and they said, well, I'm glad I survived. And there you are and say, okay, let's talk about how can we plan for safety and how can we get you in treatment. And this time span can be very short. So there are recommendations saying that there should be a contact within the first days that you could speak to them, but it should be in any case within 3 days, because we often find that this is a critical time window, and later on when they're discharged from hospital, they go back to their lives, they found that their problems have not changed and continue there. So you have to go to them in the emergency room as soon as they're ready to talk and start there. This is a window of opportunity that you don't get later on. So to evaluate past suicidal behavior, these are the things you could ask for. Of course, suicidal ideation, intention, plans, what was the motivation, what was the puffer, the deterrence, or what kept you alive, if there was such a thing, and also what were the triggers for suicidality, so what brought you there. For evaluation of past suicidal behavior, you can see what happened, how often, in which context, also looking for triggers, how high was the potential lethality, and what kept you alive. And when talking about risk factors, you can also look into these modifiable risk factors, or are these risk factors that you can't do anything but accept them. For example, okay, a parent of you died, this is not something that you can change. Whereas for all of the psychological dimensions, like hopelessness, psychache, decreased self-esteem, narcissistic trait perfectionism, these are things that you could change using therapy, or mental health disorder, for example. You cannot change things that happened in your past, but you can maybe change on how you see them or how you perceive them. There seem to be some specific stresses for adolescents, feelings of shame. It's a very specific stressor because they are in a social environment most of the time, and it's the time of their life when how others perceive me is of crucial importance. So shame has a much higher weight in adolescents than adults. Bullying or social ostracism, feelings of being a failure, or fear to lose a loved person. There's this now very old AK parameters. It's nearly 20 years old. There's not a new version, so this is, but it's still a nice thing to think about. So it says, who are the attempters who are at greater risk for suicide? These are those with a suicidal history, of course. They're still thinking of suicide and make a prior suicide attempt, who are male, who live alone, who are depressed, or manic or hypomanic, severely anxious, or substance abusers, who are irritable, threatening violence to others, hallucinating or agitating. Those need to be seen, of course, by mental health specialists. So now you have all your assessment. Now it's time to decide what to do, actually. So, and you can think about risk levels. High risk levels would mean that you have somebody sitting there with severe mental health disorder, acute stressors, and no relevant protective factors. You have a potential lethal suicide attempt or persistent thoughts with severe intentions or playing through the attempt in the mind. Those are people who will need to be admitted to inpatients. And they need to be taken also at inpatient units steps to watch them carefully. So some surveillance. Then there are the cases with lower suicidalities who have modified risk factors from protective factors. These are the ones with suicidal thoughts but without intention, plans, or behaviors. It's good for safety planning and outpatient treatment. And then you have the ambiguous ones, and this is probably because it's not arguing about them, but there's a lot of thoughts they have spent on what is the right treatment for those with a moderate risk, meaning those with multiple risk factors, low protective factors, who have suicidal thoughts with an intention to die, have some sort of a plan, although not all too concrete, but they could be right for inpatient admission, but maybe some safety planning and seeing them frequently in outpatients also work. And then there's documentation. Never forget about that. At least where I come from, also for legal issues, it doesn't count whether you said that you talked to a patient, as long as it's not written down, you didn't do it. So, and this is just to show you that documentation doesn't have to be a lengthy thing. You just need to provide information about the risk level, your reasons for choosing that risk level, and your treatment plan to reduce risk. I think these are the things that need to be in there. So to give you an example, The 70-year-old patient has lost his job 2 months ago and can be diagnosed with a major depressive disorder. Although he states having no suicidal ideation, his risk is seen as moderate to high, given that he was brought to the emergency department after an interrupted suicide attempt through hanging, and his mentioned hopelessness as well as severe alcohol and THC consumption. The patient will be admitted to the inpatient ward with constant surveillance, re-evaluation tomorrow morning. So this would include everything. It's very short. So everybody can have enough time to take that down. As it says, this risk level, how did you come to choose the risk level, what was the treatment plan? So to involve you more in that, which are the risk factors to see, and what would you recommend for this patient? Just take your time and read through it. Everybody got through it? So who would be in favor of discharging this patient? Who would be in favor of inpatient treatment? Yeah, okay, inpatient treatment, yeah, I would agree. So what are the risk factors that come up in that? Of course, I put a lot of risk factors in there. It's a whole risk factor case, but what are the interrupted, yeah?
Previous attempt.
Previous attempt, very good, yeah, go on. Sorry? Being a male, very good. Hardly nobody gets that, yeah, but that's very good, yeah?
Mounting pressure.
Yeah, pressure is increasing.
Hopelessness.
Hopelessness is in there, yeah.
Sleeping.
Sleeping problems. Yeah.
Age.
Age, very good. Another demographic risk factor, so it's above 15. Yeah.
Symptoms of depression.
Symptoms of depression. Yeah.
Regretting being safe.
Yeah, he regretted being saved. So he's the 1% of them.
Nobody has noticed.
Nobody has noticed, so there's problems communicating in the family. Stresses. Yeah. Wow, you're very good. I think you have everything in there. Yeah. So this was an interrupted attempt. He intended to kill himself. He did it before. There are acute stresses. Girlfriend broke up. There are some depressive symptoms in there. There's some sleeping disorder, and he regretted it. So what can you? Of course, there will be an inpatient case, but what needs to be done, also in less severe cases, is safety planning, because we have some good evidence that stops or at least decreases suicidality. I don't know if you're familiar with the concept of Barbara Stanley's safety planning, and this can all be found on the net. So there's this form that you can find there if you Google for it. It's a very, very easy concept. It says you sit down, take this page, and go through it with the person you're talking about. The first level is step 1, warning signs. 3 things that you see are my warning signs for an increase in suicidality. The second step is internal coping strategies. Which are the things I can do to take my mind off my problems without contacting any persons? So these are my internal coping skills. And it's just about distraction. It's not about ruminating about your problems, but just distraction. Listening to music, going for a walk, taking out the dog, whatever. Calling a friend. Step 3 is people and social settings that provide distractions. It's not people you talk about your problems with, it's you just go to places or to people so that you get distracted. You can fill in the phone number of them and the place here. The next step, and you see it's an escalating steps, people who I could ask for help. So now I'm talking about my problems. This is maybe another group of people other than the one at step 3, also the phone numbers, and then it's the professionals or agencies I can call. And here you fill in the numbers where they can turn to. Suicide prevention line, whatever. And then at one point making my environment safe. So this is for the ones you're talking to and say, well, I've hoarded some pills. Well, it would be a good idea to better give them off to your parents. That's how we destroy them. And safety planning, this is a very recent study, seems to work. So this is a randomized controlled trial. In adult studies in the emergency room with a very huge number. So what they did was safety planning plus, meaning that they did this form that I showed to you, and 2 telephone contacts, maximum of 72 hours after, with regards to usual care, so do whatever you do. And you can see here that the proportion of suicidal behavior dropped significantly in those with this. This is a minimal intervention. It's filling out a one-pager and calling them twice. And you can make a tremendous difference in suicidal behavior in those who attempted suicide on the long run. So it's nearly halving the odds of suicidal behavior if you do this very, very short intervention. And of course, apps are everywhere. Now there's a safety planning app as well. That's called Bright app. So what they did, and this was done with adolescents, 66 suicidal adolescents, who were inpatients. So they were given 3-hour intervention inpatient ward in safety planning. So they spent some more time on that, and I gave them the Bright app. So that's an app that's often providing some sorts of distractions, but even strategies to cope. They did find no statistically significant differences, but this is probably due to the low number, because you can see here that it's nearly half the suicide attempts in those who were giving the Bright app and the ASAP intervention. And they had a longer time to suicide. So what can you do in treatment?
So you do this safety planning for everyone?
Who mentions suicidal thoughts, suicidal ideations. We're just using the form, and we're having them come back within 1 week if it's not a very strong suicide ideation, or daily if we can discharge them.
And phone calls are available for them?
Yeah, phone calls are available for them. They can reach us anyway 24 hours. But in our system, we're just using the form of Barbara Stanley, and then we see them personally within a 1 week time frame for those with a low level of risk. There are 2 systematic reviews showing that interventions are effective, but there was no difference between intervention groups and treatment as usual. But one could see that including families increases efficacy. And there's a very recent new therapeutic systematic review on therapy, including 21 studies. In 5 studies, intervention group was better than treatment as usual. The only replication you could find replicated effects was for CBT and DBTA. It reduced suicide attempts and self-harm, and these are also the ones with the best outcome. And for suicide ideation of the suicide attempts, there was also a resourceful adverse parent program, MBTA and TBTA, which showed to be efficient. But the question is, what do all these effective programs have in common? Well, they involve family, and this is a lesson to be learned. If you're working with suicidal adolescents, it increases your efficacy if you involve family members, a close person. All of them focus on emotional regulation. All of them provide problem-solving skills, and all of them work on communication skills. So these are the things that the effective programs all have in common. Just some recent data on DBTA versus individualized and group standardized therapy. So they are trying to get the same frequency as DBTA as a comparison to DBTA by providing group plus individual sessions. And you can see here that at the end point, be it suicidal attempts or self-injury, they all come out the same. DBTA is a bit quicker, but one thing you can learn from it, the treatment as usual works pretty well. So just by seeing the person and by including their parents, you do a great deal of work, even if you're not specialized and a DBT trained therapist. And there was no difference at 12 months follow-up. And this is just a single arm DBT study, also showing very recently a decrease in suicide attempts. So DBT works. Just for a quick look into psychopharmacology, you probably are aware of the fact that ketamine, at least in adults, seems to be an has anti-suicidal properties, mostly being, there's even a systematic review now with 25 studies showing that it's effective at 4 hours past administration, and I've seen it personally myself. So you have a very suicidal patient, a 14-year-old one in that case, and you administer ketamine, and 1 hour later she said, wow, I never thought that this would happen, but at the moment I don't think about suicide. It's fascinating to look up from the outside. It doesn't work all the times. It was just an example that's very quick. Normally they're using 6 ketamine infusions in 12 days. This is then protocol, but I don't know, you've probably heard that the FDA approved ketamine nasal spray in last year, esketamine that is, for treatment-resistant depression, so that's another way of applying that. So I'm going quickly over that. There's also a case series, at least in adolescents, of 13 adolescents for treatment-resistant depression. They didn't look into suicidality, however, they were able to show that there was a decrease in the depression. The mean decrease in the CDS was 43% and the response rate of 38%. And those were adolescents who didn't respond to 2 antidepressants before. One thing that I'm going very briefly over because I'm losing out of time at therapeutic assessment. There's a manual for it, you can read it through. It's a very efficient way of dealing with the first contact. So therapeutic assessment developed by Dennis Open at King's College and Toby Sandel was not intended to work as a therapy. They just had, because they were responsible for the emergency room assessment of suicidal self-harming adolescents, and they always gave them a follow-up psychotherapeutic treatment date, but some of them never showed up. And they thought about how can we get the first encounter as good as possible to motivate them to come back. And they succeeded. There's a randomized controlled trial. This was the first one. There are 3 on by now, all showing the same thing, that those receiving therapeutic assessment come in therapy more often, they stay longer, and they visit more sessions. And this only lasts 20 minutes. So what do? In the very first encounter, they take the history, do a suicide risk assessment, and if they know that they can discharge the patients and send them to outpatients, they ask them, okay, I think I understood some of the things that you told me. Do you like us to make sense of what you told me? Shall we try to put it down? And this coming from cognitive analytic therapy, they take out the paper and they create a graph, which is not more than a vicious cycle. And it normally follows this thing, so interpersonal problems lead to